Hey guys, what's up? Usually I don't like to record like this, but unfortunately I lost my Apple Pencil, and I've been wanting to make videos, but I haven't been able to because I lost my Apple Pencil. I went ahead and wrote this out here, and today I just wanted to talk very briefly about acute myeloid leukemias. And so there are many different types, and um, it can be very challenging, I think, at least when you're starting off and learning it. I find it challenging to keep all of the different criteria straight and then all of the different differentiations straight. So acute myeloid leukemias can be defined by differentiation, which I'll be talking about here. And then it can also be differentiated by genetic abnormalities, which I will not be talking about here. But if we think about the different types of AMLs, there's going to be AML-NOS, which is kind of subdivided into all these other ones here. There can be AML with minimal differentiation, AML without maturation, AML with maturation, acute myelomonocytic leukemia, acute monoblastic monocytic leukemia, acute erythroid leukemia, and acute megakaryoblast leukemia. So these are separated too sometimes into number classifications. So AML with minimal differentiation is M0, without maturation M1, with maturation M2, and then myelomonocytic is M4, monoblastic and monocytic is M5, erythroid M6, and megakaryoblast is M7. So generally when we think about the acute myeloid leukemias, generally, the patients are going to present with an elevated WBC count due to circulating blast in the peripheral blood. And then when we think about blast cutoff, I know that this can get kind of wishy-washy and confusing, but this is what I'll say in this video. You may find different things in different resources, but blast count greater than 20%, you call it acute. Blast less than 20%, you can still call it an acute, but then they would have to have translocation of 821, a translocation of 1517, or inversion of 16. In general, markers for AMLs are going to be CD34, CD13, CD33, HLA-DR, and CD45. Of important note too, APML is going to be negative for 34 and HLA-DR, so you may get asked something like that. If it's a negative for HLA-DR but it has all these other markers and looks kind of myeloid on morphology, then you should be considering APL. So I'll talk about specifically here acute myelomonocytic leukemia, which is M4. I just had a case on this in the hospital, so I thought I would look into it a little bit more and just present some basic details. So with non-erythroids, you're counting about 20% or more monocytic cells, and then 20% or more neutrophil cells of neutrophil maturation. In terms of immunophenotype, it's going to present with CD113, CD33, CD4, CD14, CD11B, and CD64. CD64 is a monocytic marker. That's important to remember. And then when you think about the morphology itself, you're going to see promonocytes and blasts. Promonocytes are kind of categorized under blasts when you're doing the counts, but they are technically not blasts, so just keep that in mind. They are promonocytes, so they are precursors to monocytes. So when you see a monocyte, usually you'll have like irregular nuclear contours with irregular nuclear folding, which I kind of demonstrate here, some nuclear folding and overlapping, fine chromatin, of course, and 1 to 2 prominent nucleoli. And blasts are kind of the typical looking blasts, so pale blue cytoplasm and azerophilic granules as well. So that's what I have for this intro to AMLs and acute myelomonocytic leukemias. I hope it helps, and good luck studying. Let me know if you have any questions. Thank you. Bye.